it's a pleasure to be involved in NRP 78, and it's really nice to see the progress and follow up on your output of your research. The pandemic is not over, despite our desirability bias for it to be over. In fact, with the emergence of Omicron, WHO had to redraw, or rather rescale, this figure so that the wave of Omicron would fit. So the Omicron wave is far higher than all the previous waves. But there's one thing that we also need to notice. Increasingly, we see a decoupling of deaths and cases. So I think it's a black line. The black line represents the number of deaths. And if you look at the very early start of the pandemic, obviously there was a much higher ratio of deaths compared to the reported cases. And that was, as you know, due to under-testing. But really, with the second and third and fourth wave, it was almost a parallel wave between cases and deaths, which we do now not see anymore with the Omicron wave, due to the higher, due to four factors really, that we now see this decoupling. One, we have now a very high global vaccination coverage rate. Two, we have also increasing infection-induced immunity rates. Three, Omicron inherently, luckily for all of us, is associated with milder disease. And fourth, I think we're also getting better in treating and managing severe disease. There's another thing we learned from this figure, and this is that in fact, cases are declining globally. So every week there's about a 20% decline. But don't be fooled. Although this decline is probably truly reflective, we also need to know that people are testing less and less. Because of the availability of antigen tests, and now the milder nature of this disease, people don't go for PCR tests and so we don't get reported to WHO. So there's also a higher decline than in reality. Plus, as we all know, currently South Africa is seeing a new surge, China is seeing a surge, Hong Kong is seeing a surge. So don't be fooled by those data. And really, we need to continue emphasizing the need for SARS-CoV-2 testing and continued surveillance. We cannot become complacent, and we will not be able to monitor the epidemiology unless we continue with testing. So what is the status of vaccine coverage rates? Very encouraging. So remember, the global population size is about 7.7 billion. 11.6 billion doses have been administered globally as of 2nd May. And fully vaccinated is at now 4.66 billion. So about close to 60% of the global population is now fully vaccinated. Really encouraging, but remember, we still have inequity with some countries having far higher than 80% coverage rates and some still struggling to get beyond 10%. But also remember, this does not now reflect anymore vaccine supply constraints. In fact, we have sufficient vaccines. The vaccine supply forecast is enough to cover 70% of the entire population by June this year. So it's not vaccine supply anymore. That was the talk of last year. We now have enough vaccines. This year, it is the problem of delivery. So some countries, even if you send them the vaccines, they have a problem delivering to the people and giving into the arms of as many persons as possible. WHO, together with many academic centers, also tracks the global seroprevalence rates. Starting from about the second quarter in the first pandemic year, we saw a steady increase in the seroprevalence rates. And from about, we started vaccinating in about January 2021, then you now also see that seroprevalence is being contributed also by increasing vaccine coverage rates. But overall, the increase in seroprevalence is driven more by the infections rather than vaccination. And so much so that prior to Omicron, the seroprevalence, the average was around 60%. Now, in the during or post-Omicron era, we are in fact far higher than 80%. But also there, be reminded, there is a lot of heterogeneity. That means it varies between regions and between countries, with some countries still having extremely low seroprevalence. China is the model example here. But Africa, for example, now has rates far above 90%. So globally, on average, I think about 70 to 80% seroprevalence rates now, which is also good news for all of us. So what are factors that continue to drive SARS-CoV-2 infection and the impact? And we should differentiate between drivers of transmission and drivers of impact. Drivers of transmission include the virus evolution, with increasingly variants that we see with immune evasion, but also the fact that we have worldwide still pockets of susceptible populations, either because of lack of access to vaccines or delivery problems to vaccines, vaccine hesitancy, which is not a fringe anymore, but has become close to mainstream in some parts, or also, and we still do not fully understand, the duration of either vaccine-induced or also infection-induced immunity. And we do see waning. Plus, of course, inappropriate and inconsistent use of public health and social measures. And lastly, and sadly, misinformation, disinformation, politicization that result in false narratives and really are hindering our response. Drivers of impact are our increasing vaccine coverage rates. We can still do better, although I think we should all celebrate also our success. The duration of protection, the access to life-saving tools, and that's beyond vaccines, that is also, just having access to oxygen. And we are getting better at giving therapeutics. And of course, drivers of impact are what is going to happen with future variants. And when we look at variants, we always look at three characteristics: transmissibility, clinical severity, and properties of immune escape. And immune escape is particularly important because that will result in reduced vaccine effectiveness. Drivers of impact also include management of COVID-19 conditions and our capacity to react quickly. So really, if you ask us what are the determinants of future trends, it is driven by the increasing population level immunity. And here we're talking about vaccine-induced as well as infection-induced immunity, or the combination of both. And the combination of both is called hybrid immunity. But we also see for both vaccine and as well as infection immunity, unfortunately, a waning over time. Increasingly, we seem to see a seasonal pattern, and I guess that pattern may become stronger in the future. But who knows? Never ever learn and never ever extrapolate from influenza. That's always what I say. And then there's, of course, continued virus evolution, and it could go into all directions. So this is now, let's go into the variants of concern, and as we know, Omicron is now the dominant variant circulating globally, really presenting 99% of all specimens collected, with little trickle still of Omicron. But basically, the Wuhan, the ancestral, is extinct. In fact, we eradicated Wuhan, the Wuhan strain. So the variants really all started or emerged in settings at a time of high virus circulation. That's very important to say. Alpha first in the UK, then Beta, and for some reason, Beta never really took over the scene as we thought. Instead, it was Delta that emerged in India that took over, but luckily did not have so much of an immune escape. And then Omicron took over, has the worst immune escape of all compared to all previous variants, and is more transmissible than all previous variants, but also has some good news. So let's go and hone into these Omicron subvariants. Interestingly, and I'm not a virologist, we would expect, also extrapolating from influenza, which you should never do, you would expect a linear viral evolution. This actually did not happen. It's radial. So you see in the blue cloud, you will see it's radial from the Wuhan sub, Delta, Beta, Alpha, and they're quite dissimilar. But Omicron is totally different. Omicron is, first of all, antigenically the most remote to the Wuhan strain, antigenically the most distant to the original ancestral strain. And of all those Omicron variants, BA1 is actually the most distant. BA2 is less distant. We now have BA3. And as you've seen in the news over the past weeks, in South Africa, we have now BA.4 and BA.5 emerging. And we're now trying to learn about the clinical severity. But again, it looks promising. So the Omicron is so separate that some have suggested that we should rename it to a different serotype, a serotype 2. So that has not officially been done, but people are thinking of it because it really behaves differently. Also clinically, it's much more an upper respiratory tract infection than a lower respiratory tract infection. It also doesn't have so much all the other complications, including probably less long COVID and smell and taste issues. So what is the impact of the Omicron in terms of its immune escape mechanism and its impact on vaccine effectiveness? So and that's in fact one of my tasks, we really look at every single vaccine product and look at the impact on two parameters, two clinical endpoints. One is severe disease, and one is what we call symptomatic infection, which includes everything. Both are important. But the most important, of course, is to reduce severe disease, to reduce hospitalizations, protect healthcare systems, and prevent deaths. Of course, we also want to see protection against mild disease, because mild disease reflects circulation, and that will drive the emergence of variants. But from a public health perspective, the prime objective is to keep the number of deaths down. And you can see here in the upper line that is for Delta, actually the vaccine effectiveness against severe disease was maintained, remained high, whilst there was a drop for protection, VE, vaccine effectiveness against milder disease. But for Omicron, we see also a drop in protection against severe disease and symptomatic disease, and basically hardly any protection against infection. Therefore, really there is a modest, if not minimal, if not even zero impact on reducing transmission under Omicron. This is a busy table. Again, we now try to look at the duration of vaccine effectiveness against Omicron, because this will drive, once you understand this, then it helps policymakers to decide when to give the next dose. And this is only for Omicron, and the line you see is at 50%. The WHO target profile is set at 50%. Everything above is considered satisfactory, below unsatisfactory. And you see that the vaccine always performs better against severe disease, which is what we want. And it doesn't perform as well against symptomatic disease. But you also see that with the primary series, which means just the 2 doses, it really drops very quickly below the 50% mark, especially if the primary series was given more than 6 months ago. Omicron really taught us you need a booster dose. So the booster dose, you see then everything moving again to the right. But again, a few months later, you will see already a drop. So we have a problem with the duration of vaccine effectiveness, and that is our biggest headache for the future. You're asking me about the future? This is what we have to deal with. So in summary, for the Omicron, it's current dominant VOC. BA.2 is the current lineage that's circulating globally. We're now seeing 4 and 5. But there are also several recombinants called XD and XE, and various other, there are, I think, already 50 smaller sub-lineages from the Omicron. The good news is VE remains high for severe disease, but is low or non-existent against infection and transmission reduction. So the whole world is now discussing the need for variant-adapted vaccines. The immune response to Omicron is really becoming increasingly complex. And for policymakers like WHO, we are now at a stage that is totally different compared to 2 years ago when we were all naive and all had to be vaccinated. Now we have situations where some people are naive, others have been previously infected, others have been previously vaccinated, others have been previously vaccinated and infected, and this combination is called hybrid immunity. So we really also, and the hybrid immunity may drive decisions on whether there's a need for a booster dose or not, or whether we can even reduce the number of doses in the primary series. Colleagues of ours, they created a heat map. So they looked at 20 studies, giving 49 estimates comparing the vaccine effectiveness in a person with hybrid immunity compared to the vaccine effectiveness in someone who only had natural infection, so infection-induced immunity. If it's green, it means hybrid immunity is better than infection alone. If it's orange, then in fact it does not help. And as you can see, there is no orange. So in other words, the vast majority of these studies underline that hybrid immunity is better than infection-induced immunity. This is important for your messaging, because some countries now think, oh, we now have 80% seroprevalence, let's stop vaccinating. There is still a major advantage of continuing vaccination even in high seroprevalence settings, because hybrid immunity is superior to infection-induced immunity alone. If we want to talk about the future, we also need to understand the origins, and unfortunately, SARS-CoV-2 is a zoonotic disease, and I always teach my students, zoonotic diseases are always difficult to eradicate, in fact, close to impossible to eradicate, except for SARS-CoV-1. I was in Singapore at that time, and we took all measures, and we were able to, and China, and we were able to actually eradicate this. We all think it was a single event of a cross-species jump, probably from bats, knowing that there's a high homology with bat viruses. For this virus, for SARS-CoV-2, we actually do not know the intermediary reservoir, but there was a reservoir. And so we need to strengthen our surveillance in animals because it could spill back over from animals. In fact, it may also mutate differently from animals. And that was one of the theories initially with Omicron. I'm not so sure whether that holds true. So, you wanted the worst and best case scenarios. Let's start with the best. In fact, the utopia one. Omicron is our last variant. Dream away. The optimistic or best case is that future variants will increasingly be less and less severe, so mild disease, and that it will be so mild nobody would care and we would not even need periodic boosting. The working likely scenario, though, is, and we all think this is the most likely, and that's what we're working with, is COVID becomes manageable, and that means it's not a crisis anymore. We don't need to reinstate all our lockdown measures. We may have an occasional flare-up. It may be some seasonality, and we need to work with this. The worst or a pessimistic scenario is, well, the next variant actually could be more virulent, even more highly transmissible, and we could have another big wave. Or the worst even is a reset with a totally new virus, or totally recombined virus. Whatever it is, all future scenarios will need to plan for managing post-COVID-19 conditions. There's a whole, don't want to go into detail, but there's a lot of working groups and technical advisory groups working on the variants. And especially currently, I can tell you, there's one group working on the vaccine composition, trying to tell the world to tell the companies and the manufacturers which next vaccine to work on. Extremely difficult, high-risk endeavor. We need to end the COVID pandemic and really move from epidemic control to sustained disease control. That includes a whole series from vaccinating to tracking to strengthening communities, rebuilding trust, and we need continued investment and funding of these efforts. And really, ideally, the whole COVID response that was reactive because of the pandemic should now proactively be built into a sustainable structure that integrates with respiratory disease preparedness and response coordination beyond just COVID. Really, we need better surveillance, tracking, we need new tools for countermeasures, we need really engage in community readiness and resilience and improve our delivery. In conclusions, herd immunity, we all wish for, and we again try to learn from measles and others, is elusive for COVID. It is endemic, and it will continue because there is also a zoonotic potential spillover. Current vaccines are good at preventing severe disease, but unfortunately not good at preventing transmission. So it will continue, and we need to continue to achieve high vaccine coverage rates, especially because this vaccine offers better direct protection. So we really need to focus on the highest and high priority use groups, especially the elderly. Chasing after new variants as they come is impossible for vaccine manufacturers. And that's why there's now a call to developers and manufacturers to develop a pan-coronavirus vaccine, or also called a pan, or even better, a pan-sabecovirus vaccine. This will take many years, it may not be successful, and we have to continue using our current tools. Thank you so much for your attention.
Thank you, Annelies. Do we have questions? We have time for some questions. Not a lot, but we do. It's 1, 2.
Thank you for the talk. I was wondering if World Health Organization is tracking whether the situation with the vaccination against COVID-19 affects the vaccination against other more severe diseases. Because in some of the countries, some of the smaller children, because of the situation in the hospitals, have not been vaccinating the kids against, let's say, measles. Is there some kind of strategy planned? Thank you.
From the very beginning, as early as March and April 2020, WHO has been tracking, and there has been a major backlash, especially for vaccines that use mass campaigns, because mass campaigns, by definition, were stopped because of the lockdown measures. And we are already seeing now, because of at least a 30% drop in some of the vaccine coverage rates for routine immunization in children, we are already seeing a resurgence of measles and various other diseases. So we will have another epidemic of vaccine-preventable diseases, which we could have prevented. So there's a lot of effort going into catching up those who missed out in their initial birth year.
Other questions?
Hello. Maybe I can squeeze in 2 questions. I was surprised not to see any mention of something that's recently come on the market and seems like it could make a big difference in the future outlook, and that is antiviral therapeutics, small molecules like pavloxid, which at least with severe disease seems like to be perhaps a game changer, access issues notwithstanding. Yeah, I'll just...
Sure. So therapeutics will play an increasing role to mitigate and manage and reduce case fatality rates in those who are already infected. It's my personal bias because I work on vaccines, so I can't give you any details on antivirals.
Oh, that was an extremely short answer, so I think we can take one more question if there is one more. Kai has one, I think.
Just a practical question. Should we get booster shots at this point, in particular if you are kind of 5-6 months after your 3rd shot?
So, yes, a very, very important question. And countries are issuing different policy recommendations. So it's a wild, wild west on the policy. So I think we all agree you need a booster dose. That is, I think, no more discussion. That policy has gone out. It's about the 4th and 5th doses. So WHO recommends a 4th dose for everyone who has any immune compromising conditions. But WHO is still is more careful, recommending a 4th dose on a general basis. And it is weighing up the programmatic challenges of a 4th dose compared to a relatively marginal benefit. So we all agree, giving a 4th dose and a 5th dose, every time it does increase your neutralizing antibodies, and you get an impact for some time that is better than if you had not given it. But it's increasingly marginal, so it's very marginal. And we are often misled because we use relative vaccine effectiveness. So the absolute attributable vaccine reduction, I didn't get the word right, is actually quite minimal. So we currently lean towards saying wait and give it at the time when you expect your next surge to come, which is usually before the next cold season. So for the Northern Hemisphere, it would be in October or September. But for the very frail, the very vulnerable, the really older people, why not? It's the same thinking as in immune-compromising conditions. So some countries now recommend it for the age of 60 and above, some only 18 and above, some don't give it at all.
It's just that many countries are requiring it as a condition for entry. So yes, the last time I looked, I was asked to have a valid COVID certificate, which is not longer than 6 months old. And at this point, the Swiss one will expire, so I can't travel. So I think that's another issue which one has to think about.
Yeah, that's a logistical issue. And I think Switzerland will come with a solution, and it may not be the 4th dose. They probably will extend. I want to hear as well. I'm in the same.
I don't care about travel to Switzerland. They have to let me in anyway. I traveling elsewhere.
Yeah, but that is a logistic about the duration of your certificate. It has nothing to do with the science. This is a logistical issue.
Thank you very much, Annelies. And thanks for